thanks very much. I'd like to thank the Kidney Foundation for organizing this event. It's really been, I think, quite an impressive day of very controversial topics that need to be discussed in this forum. And thank you very much for the invite. The topic of high-risk communities is a tricky one. And I'll tell you right up front that there's no easy answers to this. I mean, there's no easy answers to any of the stuff we've talked about today, but certainly I think this is an especially challenging area because it highlights many of the issues that have already come up today, and it's exponentially greater because there's that one additional barrier that comes into play here. So I'll start with a generic kind of talk on the notion of health-related disparities as it relates to kidney disease. And anyone that's followed this literature and looked at it knows that there's lots of news reports and lots of studies that have been done on various health-related disparities. There's not an area of medicine, I think, where some element of a disparity hasn't been described, either in terms of access to care, the type of care, and outcomes after the care is received. And so kidney disease is no different. This is data looking, some of it's United States data and some of it is Canadian data, but it's looking at the prevalence of kidney disease. And we know without any uncertainty that there are many subgroups that are at higher risk. Aboriginal or First Nation groups, South Asian groups, East Asian groups, the African American population, anyone that's of a lower socioeconomic status. All these groups have been identified in various different studies as having an increased incidence of kidney disease. So we know that this group is overrepresented, and these groups are overrepresented in the kidney disease population. Now, we all know, and we've heard, that transplantation is the gold standard therapy that we want to try to offer all of our patients. But we haven't talked a lot about what it takes to get there. The focus clearly is on donation, but I do think it's important to take a few minutes to talk about what patients have to go through to get to the point of getting a transplant. And this slide doesn't show up very well, but essentially, once you're diagnosed with kidney disease, you have to be eligible to get a kidney transplant, which means you have to not have certain medical contraindications. You have to be in a certain state of health so that you can actually safely go through the surgical process. You have to be referred to a transplant program where you're going to get assessed. And depending on your blood type and depending on what your previous exposures have been in the medical system, you may have quite an extended wait time. So you've heard that your wait time for a deceased donor kidney transplant in the province of BC range anywhere from 3 years if you're blood type A to as long as 10 years if you're blood type B. So even within the patients that have kidney disease, there's a huge variability in terms of what your access is. The other important mechanism that we actually we try to help promote to help patients get a more timely transplant is through identifying a living kidney donor. And that's easier said than done. There's a very difficult process. If you're fortunate that you have a loved one or a friend who's willing to come forward and do this, that person still needs to go through their own process to make sure that they're medically suitable to donate a kidney. So there's a lot of steps that have to be in place and a lot of navigation of the healthcare system that has to go on in order for you to facilitate a transplant. Now, there are numerous racial and ethnic disparities in kidney transplantation that have been described. This is data from CIHI, which captures data in the Canadian Organ Replacement Register, and they recently published a report looking at First Nations and Aboriginal care and management in end-stage renal disease. So this is simply looking at what happens to patients who are Aboriginal versus non-Aboriginal in terms of what type of therapy they're on for once they have kidney disease. So on the bottom there, you can see that transplantation is the bar. The green bars look the same as I look at this, but the bar on the left-hand side is the bar for transplantation. And if you look at that compared to non-Aboriginals above that, it's smaller. So you've got, of patients who are have kidney disease, Aboriginals are much less likely to be transplanted compared to non-Aboriginals. If we look at other ethnic groups that are common or large groups in Canada, although admittedly these are broad categories, but East Asians are almost 30% less likely to undergo kidney transplantation compared to Caucasians. Indo-Asians are 30% also less likely to undergo kidney transplantation. So clearly these are huge differences in terms of access to transplantation. Now, an important subset is living donor transplantation. So when you look at just living donor transplantation, East Asians are 73% less likely to undergo a living donor kidney transplant, and Indo-Asians are 58% less likely to undergo a kidney transplant. So huge disparities. So the question really to be answered is what prevents these populations from accessing the best therapy for patients who have kidney disease, which is transplantation? Well, this is where it gets tricky, and I think that if you look at the literature and where we've been, these observations have been described for decades now. We've known, you can find studies from the 80s and the 90s that have gone and described these disparities. But unfortunately, we haven't really moved beyond these observations. So we're kind of stuck at the notion of this is what it is, and how do we move forward? And we're still struggling with how to really move forward here. And so there's a number of theories that have evolved in terms of why this may be. And I'll use the term theory because, quite frankly, I can't say they're fact because we haven't proved any of these. So we're really in a theoretical realm here. So the first important consideration is that perhaps there's a lack of motivation to pursue transplantation. And this can be on many fronts. So patients, as I said earlier, there's a lot of work to actually get to the point of getting a transplant. Well, patients, their families, and perhaps even some of their physicians may not appreciate the benefit of transplantation in all populations. Now, that seems like a crazy idea when I say it. Well, why would it be different in different populations? But there is some data to back this up. So in the US, there was a survey done, this is a number of years ago now, but where they surveyed nephrologists in terms of whether they felt the kidney transplantation would provide a survival advantage to different patient populations. And 69% of surveyed nephrologists believed that transplantation would improve survival in African Americans compared to 81% that believed it would provide a survival advantage in Caucasians. So even in a quote-unquote educated group of professionals who are taking care of patients with kidney disease, there may be some misperceptions there. For the record, that's not true. The outcomes are equally good after transplantation, irrespective of your race or your ethnic status. So this is data on the top here, just looking at the survival after transplantation in patients that are white, East Asian, or Indo-Asian, and you can see that the outcomes are great in all groups, and there's no significant difference there. On the bottom there, you've got different, what we call graft survival, so the percentage of patients that have a functioning kidney at various time points after transplantation. So Aboriginal patients have, 84% of those patients have a functioning kidney at 5 years, no different than what you're seeing in the non-Aboriginal populations. So if anyone tells you that there's a difference in terms of the outcomes of different ethnic groups, they're wrong. The second major theory is that there's a lack of enthusiasm for living donor kidney transplantation in particular. And I know the focus here is deceased donation, but it's very hard to tease these two issues out. So I will talk a bit about living donor transplantation as well. So what do I mean by that? Well, I've told you that transplantation is the best form of therapy. From the recipient's perspective, from a patient's perspective, a living donor transplantation clearly is the better option. It bypasses the wait list, so you have much faster access to transplantation. B, as a result of that, you've got less dialysis exposure, so all the complications that are associated with dialysis are mitigated. And C, you've got better outcomes, both in the short term and the long term. With deceased donor transplantation, for all of its merits and for all of what it accomplishes, it's a more complex surgical procedure. Someone has passed away, and you're taking that organ, and you're transferring it, and then you're doing the transplant. And it often happens in odd hours of the day, and so there's an increased layer of complexity there. With living donor transplantation, that is a much more simplified process. And so we see that in the outcomes after transplantation. On the bottom there, I've simply highlighted what our numbers are for deceased and living donor transplantation in BCU over the last 20 years or so. And what we see is that living donor transplantation has certainly sustained us through periods where deceased donation has not met up. And that's really been one of the major reasons why we've seen advances and growth in transplant numbers. Now, this is a breakdown of living donor transplants in different racial and ethnic groups. And so in the blue here, I've simply taken this is the total number of transplants broken up percentage-wise by how many of those transplants were living donor transplants, how many were deceased, acknowledging that living is really the goal here if we can in this patient population. So in Caucasians, we have just around 68 to 70% of Caucasians had a living donor transplant compared to a deceased donor transplant. And as soon as you look at all the other ethnic groups, whether it's East Asian, South Asian, or First Nations, or Filipino, you're seeing a much smaller percentage of those patients that got a living donor transplant. So a huge difference highlighted there. And this is in BC. So why is this the case? Why are living donor transplants less common? Well, there's a number, again, theories that are out there that would suggest this. What we do know is that in general, if you look at people who are less likely to get a living donor transplant or less likely to identify someone to be a living donor, generally speaking, those people are less knowledgeable about the merits of living donor transplantation. So they may not know some of those benefits that I just showed you of living donation. They're also less knowledgeable about the safety of living kidney donation. And Dr. Goldberg showed you some of the more recent data that's looked at some of the risks of living kidney donation. So I'm not saying that living donation has zero risk associated with it, but when you contextualize those risks compared to general risks that we have in life, there's no bones about it. Living kidney donation in the right person is a very safe procedure and actually has very little impact on your long-term outcomes. The other issue that's important is there are people are less willing to actually approach their family and friends. That's a very critical issue. We say it like it's nothing. You need to go out there and you need to try to find a potential donor. That's no easy task. In order to do that, you need to be in a comfortable scenario where you feel comfortable actually putting yourself out there, telling people, A, that you've got kidney disease, B, actually putting it forward to say, would anybody in my social network be willing to actually donate to me, which is probably the biggest ask you're ever going to ask in your life. And then C, you're going through this whole process of hoping and seeing is anybody going to respond to this. So it's very daunting, and I think unless you have the right social supports in place, it's not an easy thing to do. It is important to understand, so I'm talking about this more from the recipient standpoint, and that's for a reason, because when you look at most people that get a living donor transplant, it's generally from people that are of the same race or the same ethnicity and even the same socioeconomic status. And that's not surprising because generally you're looking within your social network, and for the most part, those are homogenous. The third major theory is that it's not the patients. It's not necessarily just the patients and the challenges they face and their inability to go out and try to find donors. It's actually, there's simply a lack of organ donation in these communities. It may be as simple as that. And again, I'm going to look at both at deceased donation and in living donation in terms of this, just to give you a sense of what the numbers look like. And there is not great data, but if you just look at crude numbers, it does look like there's certainly less donation in these populations. So this is just a very simple pie chart that lays out the population demographics in BC. So just under 70% of the population in BC is Caucasian, and if you break people up in the green there, you've got East Asian, then you've got South Asian, about 7%, First Nations make up just about 6%, and then you've got other groups making up the remaining. And so if you actually now compare that to what the numbers look like among deceased donors and what that distribution is, it's a very different picture. So about 88% of deceased donors are Caucasian, only 4% are of East Asian ethnicity, only 2% are of South Asian ethnicity, and 3% have First Nations ethnicity. So very different compared to what the general distribution is. So certainly underrepresented in the deceased donor pool in our province. If you look at living donation, if you compare again the general population to what we see in living donors in BC, it's not quite as dramatic. And so you're seeing that again, a drop is particularly in East Asians in living donors. In South Asians, about 6% of living donors are South Asian, 3% are First Nations. So still somewhat underrepresented, but not to the same degree that we're seeing deceased donation. But the general population is probably not the best metric to compare to, because most people are not going to be a living donor unless there's kidney disease in someone near or dear to them. So if you compare this to patients that have kidney disease based on ethnicity, you see huge differences now. So a huge chunk of East Asian and South Asian patients have kidney disease, but much smaller proportions are made up in the living donor pool. So that begs the question, why? Why is donation less common in these groups? And the answer, as I alluded to at the beginning of this talk, is very complex and not well answered. And so really it's largely unexplained if I were to cut to the chase here. But I'll talk you through some of the possible scenarios and where we're actually heading with this. So the first thing that people often jump to is this is a cultural issue. This is some sort of a fixed cultural or religious objection to donation, and that's likely the most likely reason why this exists. Personally, I have an issue with that explanation because I'm not sure what that means. I think that certainly this is a contributor, that there are some cultural beliefs and there's some religious beliefs that are going to impact the way people feel about donation. But I question the fixed part of that, and I think that it's important to appreciate that most religious groups have formally come out in support of organ donation, and so I think that the argument that it's just this is a bit flawed. The other, I think, issue with this is that it's when we say something is a fixed cultural belief or a fixed religious belief, that breeds a bit of apathy on the part of us. So we feel like it's not modifiable, and we may as well just not bother trying. But I think there's a number of other issues that actually may contribute to this. So we don't know this, and this is where I say we need more data, we need more information, we need more research on this. But there may be fewer eligible donors. So if you're talking about deceased donation, only about 2 to 3% of all in-hospital deaths of those patients are actually eligible to be deceased organ donors. We're not talking every death that happens. And I can tell you that even if you look at crude death rates across different ethnic groups, it's different. So it might not be that it's a lack of willingness or a lack of consent. It might be that there's just not as much potential, at least contributing to it to some degree. The other issue is there may be a lot of misinformation, a lot of fear, a lot of mistrust, and a lack of understanding around the process that surrounds donation. We've heard a lot about the importance of trust in organ donation, and that if we erode that trust, whether it's through incentives or through any other mechanism, that's going to be a real showstopper in terms of organ donation. Well, we have to remember that when we're talking specifically about East Asian and South Asian populations, we have a large immigrant population encompassed within that. And in many cases, they're coming from health systems where maybe there's not the same degree of trust in the healthcare system. In the First Nations populations, certainly there's issues with trust in the larger system, in the healthcare system. So getting at that issue, I think, and educating people in terms of that is going to be the critical issue. It may be a lack of social supports, and that might be the major issue here. So even if someone's willing to do it, if you're within a community where people aren't celebrating the fact that you're an organ donor or people are talking you out of it, that's going to be an important issue. And then I think there's very real challenges in navigating the healthcare system. And so, as I said earlier, it's hard to get a transplant. It's also hard to register to be a donor. It's hard to register your intent to be a living donor and go through that workup. And so any challenges you have, whether they're linguistic or socioeconomic, are going to be important here. And lastly, I think the other issue is there's certainly maybe biases within our healthcare system that work against people that are trying to move towards this. So how do we actually move forward? Well, I think we need to start very simply. If we say we're going to change people's fixed religious and cultural perceptions on organ donation, I think that's a tough nut to crack, and I think that that's going to be a bit daunting. And so start with the low-hanging fruit. And let's start by answering some very basic questions and see if we can do some simple things to try to get at that. So what are some of those questions? Well, simply, how widely is it known that transplantation is beneficial and that living donor transplantation is beneficial? And we need to understand that among patients that have kidney disease. We need to understand that among patients within different racial, ethnic, and socioeconomic communities. Is that a well-known fact? And we need to understand that across the broad spectrum of healthcare providers, so that when people are engaging with healthcare providers, are they getting the consistent message all the time that this is the path they should be taking? The second thing is, are the facts on organ donation known? I'm sure all of us have learned something new about organ donation today, so clearly there's a lot to learn here. What are the principles and laws that govern organ donation? Do people understand that there are important principles and laws that govern organ donation that protect people and protect their families from from undergoing bad experiences? Do people know about the safety of living kidney donation and what the caveats to that are and how that all works? We need to have do people know that many cultural and religious groups have come out in favor of organ donation and supported this as a way to move forward? And then the nitty-gritty. Do people know how to register their intent to donate? Do they know how to move forward? And then we also have to understand within each of those, what are the barriers? So I won't go through this in detail in the interest of time here, but clearly there's patient-level barriers that people have to say what's preventing them from actually going and pursuing organ donation, what factors within their community are limiting them from doing this, and what's happening in the healthcare system that is actually laying barriers in place and making a bad situation worse for people who want to try to engage in organ donation. So there's a lot of unknowns, unfortunately, that really need to be answered, but it's not that hard if we put our mind to it and put some money into it to actually try to move forward and do this. The other important, I think, and in my opinion, one of the most critical points is, once we understand what the knowledge gaps are, it's easy to say, well, simple, let's throw an education strategy at it and go. But what does that look like? And I think that if we don't, there's a lot of data out there in the media that says, well, how we educate patients and the understanding and acceptance of that is quite variable by socioeconomic status, by ethnicity, by culture. So we need to actually understand the most effective way to inform, the effective way to educate, and then how do we actually implement some of these changes. So simple things like making sure all of our tools are not just linguistically appropriate, but culturally appropriate. So if we know that South Asians have factor X, that's the major barrier, and that might not be true for Caucasians, but we need to address that issue in their literature in terms of when we present that. Community engagement becomes key. Days like this become critical to make sure we engage large groups of people. Healthcare system engagement obviously is critical, and political engagement is a critical piece of this. So I'll end there, and we'll take some questions at the end. Thank you.